Cardiovascular disorders are the number one cause of death all over the world and also in India. Unfortunately, we Indians have fourfold higher prevalence of cardiovascular disease in the younger to middle age group compared to United States. Not only that, whatever infarctions we have, our people have infarctions at much younger age compared to the US counterparts because almost 50% of the infarctions occur at less than 50 years of age in India compared to only 10% in US. Though various scoring systems have been given to risk stratify the asymptomatic or mildly symptomatic people, but Framingham risk score is the most widely used and well validated in various large studies. And it includes age, cholesterol, blood pressure, and smoking status as well as diabetes into account. However, because this score was given much earlier, it does not encompass very many newer factors like metabolic syndrome. Because as we all know that obesity is a ever prevalent problem which is occurring with as the affluence is growing. The visceral fat, that is the abdominal fat, it is metabolically active because it secretes lot of cytokines like tumor necrosis factor alpha, interleukins, etc. And when on top of this, and this is typically, this obesity exists with other risk factors like hypertension, dyslipidemia, and diabetes, and ultimately this combination gives rise to coronary artery disease. And it has been shown in multiple studies that as the number of risk factors increase, the chances of getting event in the future increases. At present, our only things which we can do are lifestyle intervention in the form of control of obesity, smoking cessation, and control of blood pressure and glucose, etc. And it has been shown again and again that the intensity of medical therapy depends, affects the outcomes. And the patients who do not adhere do not have good outcomes. Unfortunately, the problem is, regardless of these risk factors, almost 50% of patients who have coronary events do not have any risk factor or have maybe one risk factor. And in fact, in our previous publication, we have shown that sudden cardiac death, which is the most unfortunate complication of coronary artery disease, is the first presentation of CAD in almost 1/3 of the cases. And only around 25% of patients who have sudden cardiac death because of coronary artery disease have any known risk factor. So it all means that whatever risk factors we have, it is important to control them and take care of them, but they are in any case incomplete. And in Treat to New Target study, which included 10,000 post-transplant patients, even in patients who did not have any, once they were dichomatized as per the risk factors, and patients who did not have risk factor, even then the residual risk was very high. Even coronary angiography is not helpful in telling about the future events. Atherosclerosis can be a rapidly progressive process. In patients who have undergone angiography, which we've seen time and again, and you write the report as normal or mildly diseased, and you do not do any intervention because patient does not need at time, and they typically, many of them, if they are not given statins or antiplatelet drugs or lifestyle modification, many of them do come within a short period of time of 6 months to 1 year with infarction. Why these problems are there? Because atherosclerosis is a chronic inflammatory disease. And many players are there in this fight. Immune cells like T cells, etc., interleukins, and on top of that, genetic modification is there. What happens is that various factors, they ultimately, like smoking, oxidative stress, etc., lead to endothelial injury and endothelial dysfunction. With the result, nitric oxide gets decreased, which is anti-proliferatory and anti-inflammatory, and vasoconstrictor molecules like endothelin, which is also mitogenic, increase in the endothelium, which increase the permeability of the endothelium to the LDL particles. Once the LDL particles go inside and they are engulfed by the monocytes and they get oxidized. Once they are oxidized, they release lot of addition molecules like ICAM and vascular cell addition molecule and monocyte chemotactic protein, and they attract more monocytes. And they get engulfed, resulting in the formation of foam cells. Initially, if you see, if autopsy studies in young adolescent children have shown that 99% of patients have fatty streaks, and they typically consist of foam cells and macrophages. These are normal, but they do not have any extracellular lipid particles in the arterial wall. What happens is this is a protective mechanism which nature has given to us to protect from atherosclerosis. But when it gets overwhelmed, there is too much of dyslipidemia, too much of inflammation, too many of risk factors like smoking, then this process gets overwhelmed and we get a atherosclerotic plaque which has a fibrous cap and which has a lipid pool which contains extracellular lipid. So extracellular lipid is the hallmark of a plaque which can rupture. Fatty streaks or earlier atherosclerotic features which are there typically in young people do not cause any, do not have the propensity to cause any event, because plaques as such do not cause any event, do not cause myocardial infarction. They may cause angina, but plaque rupture is the thing which results in infarction. And OCT, which gives near pathological pictures. Here you can see on the right side, you can see a fibrous plaque on autopsy, and you can see the, you can compare it with the OCT picture. And you can see how beautifully, you can see, I cannot use the pointer, but you can see over here, there is a large lipid pool. And here the plaque has ruptured, and you can see on the OCT. And thrombus is, as I said, is the integral part of the infarctions. Plaques do not cause infarctions. Now we have seen that risk factors are inadequate. We have seen that inflammation plays an important part. So now the question is, if I'm there, I'm asymptomatic, I would like to know what is my overall risk? I do not have much risk factors, but what is my risk of having future events? So as I said, atherosclerosis is a chronic subclinical inflammatory disease. So various risk markers like interleukin 6, etc. have been studied, and CRP is the most well-studied marker. It has been shown in various studies that once the levels of these cytokines, etc. are more, then chances of future events are markedly increased. CRP remains stable in a given person. If I have CRP of 2, if I do not have infection or any inflammation for next 10 years, my CRP will remain in the same range. So it has stability over decades have been shown, plus it is easy to measure. It does not degrade easily in the blood. And various, so it has been studied as a surrogate marker for inflammation. And various studies have shown that increasing level of CRPs predict poorer outcomes. And it has been shown to be as much as predictive of future events as other known markers like blood pressure and cholesterol, etc. And to Framingham score, which I pointed to earlier, it gives additional value. If two people have Framingham score, similar Framingham score risk of future events, and once one person's CRP is high, chances of the event, coronary event or death because of cardiovascular causes is much higher. And this is not only true for primary prevention perspective, but also, as in this slide show, patients who are on treatment, like in this case on antiplatelet drugs also, if the CRP remains high, chances of future events are much more higher. This concept came from Texas coronary atherosclerosis prevention study, where it was shown that lovastatin, which was used in this trial, in the treatment arm, patients who had low LDL, but continued to have high CRP levels, they had much higher event rates compared to those who had low CRP levels. It means just lowering the LDL is not enough. You have to decrease the inflammation also. And this slide in the last pink line shows that best benefit, best prevention for future events, future MI, future coronary death occurs in those patients where we are able to decrease both LDL as well as C-reactive protein. In the primary prevention study, it was shown that same thing that once in the last line over here, it shows that once CRP levels of less than 1, vis-a-vis less than 2, with controlled LDL levels, the mortality was still on the lower side on follow-up. It means, and various bodies, various guidelines have stated that CRP may be measured. And as I said, CRP is a surrogate marker of inflammation. So what are the drugs to decrease it? Presently, we have only one drug, that is statins. Statins have, beside lipid lowering, we all know, they have anti-inflammatory and lot of pleiotropic effects. And most importantly, the drugs, rosuvastatin and atorvastatin in high doses, that is 80 milligram, they decrease the CRP level by almost 40%. And how this, why this is important and why this is there is because in this last over here, you can see in the acute coronary syndrome large trials A to Z, Miracle and Prove It, which are large trial. And here the benefit from events, from the onset of, from the index event, the benefit was seen as early as 14 days to 1 month compared to low dose of pravastatin, especially in Prove It trial. So this LDL lowering cannot have such acute effect. So this effect was typically because of anti-inflammatory properties of the drug. And so this proves one point. Now this is an important slide because it shows these are large trials with follow-up of 4 to 5 years. And here you can see that once the patient is on placebo, the event rates are almost 38%. And even on statin, over 5 years, especially in diabetic subgroup, almost 1/3 of the patients. Patient is coming to you, he is diabetic, he is following all your instructions. But still, he has over 4 to 5 years or intermediate term, he has 1/3 chance of getting myocardial infarction or stroke or can die. So our armamentarium of statin is not complete. We are into a lot of research projects. We recently published that lipoprotein is important, especially in Indians. This was the study which was published in New England Journal of Medicine. I was a PI from our site, and we recruited lots of patients in Atlas TIMI 51 study, and where it was shown that rivaroxaban, which is an anti-10A inhibitor, that is anticoagulant, further prevented the events. And this drug is approved in European Union. So we need more drugs, more management strategies, because event rates are still extremely high, despite being on the best this thing. Another new concept is there. The drug is likely to come soon in India, though it's an injectable drug. It's PCSK9 inhibitor. Basically, what happens is liver has lot of LDL receptors which catch up the LDL from the blood, and ultimately through enterohepatic circulation, it is taken out in the feces. So LDL receptors are degraded by this enzyme. So there is a monoclonal antibody which is there, and which is to be given every 2 weekly in the subcutaneous injection form, and it prevents the degradation. So now liver has more of receptors, so it can catch up more LDL, and hence LDL decreases. And we are conducting this. We are continuing this trial at G. Pant Hospital, and large number of patients have been recruited which are undergoing this treatment. So there are lots of this thing. There are lots of pathways has been described. There is a nuclear factor kappa B, which once goes into the nucleus releases lots of cytokines and lots of addition molecules which promote the addition of monocytes through the endothelium. The drug which likely Cadila will be coming very soon is curcumin, which prevents this nuclear factor kappa B and also prevents its translocation to the nucleus. As I said, once this factor is there in the cytoplasm, it is inactive. Once it translocates into the nucleus, only then it becomes active and results in the release of lots of cytokines and inflammatory markers. So it acts as various points. What is curcumin? Curcumin is our routine haldi, but the pure contains very little. The drug which we'll be having will be much purer form. It will be 20 to 30 times more purer. And this curcumin has been used in traditional Indian and Chinese medicines for a long time. There are few publications, though I must say that these are only small publications. For example, publication number 1, American Journal of Cardiovascular. This was a publication from Thailand on post-CABG patients, and there they showed that it decreases the incidence of MI after bypass surgery, and also it decreased the C-reactive protein and thereby inflammation. So we have to keep our fingers crossed, though it's a good molecule, but no large-scale studies are there. Only very small-scale studies are there. In search of newer markers, lipoprotein phospholipase A2 was very much in vogue. People used to come, that's a 10,000 rupee test, blood test, and it can tell whether you can have MI or not. Because it is found in the atherosclerotic plaques, I will not go into detail. It was supposed to be a marker of vascular inflammation. It was well studied, and not going into too much detail. So a lot of interest are generated. So there were two blockers are developed. One was versaplatin, which was oral drug, and 6,500 patients with recent ACS were included in this Vista 16 trial. And see the results. This was supposed to be anti-inflammatory. And in the upper arm, that is the orange arm, that is the patients who are on study drug. They had much higher mortality. Basically, typically the event rate was much higher. This was typically because of they had much more infarctions. You are giving a drug to a person to decrease inflammation, but the event rates were much higher. And similarly, the another trial which was going on at the same time, now the drug developer of this particular this thing has stopped, daraplatin, and again, though there was no increase this thing, but there was no benefit at the same time compared to placebo of the active drug. So this is a double-edged sword. You still don't know. A small trial with colchicine, which is used in familial Mediterranean fever and gout, etc., and also recurrent pericarditis. A small trial, low dose colchicine trial, in only small number of patients, it showed that it decreased patients with stable CAD. You can have around 60-70% reduction. But this is just one study. So now this is a complex scenario. Lot of molecules are there, but like antibodies against leukeins, etc. And finally, my last slide, methotrexate is being tried. Methotrexate, what was seen was it's used as disease-modifying agent in rheumatoid arthritis. We all know it. It is given as weekly dose, 15 milligram or so. And there they found that patients who are on this disease-modifying drug, vis-a-vis other drugs like hydrochloroquine, etc., they had much less infarctions, because we know that patients with autoimmune disease like SLE and all that, rheumatoid arthritis, they have more cardiovascular problems, predominantly pericarditis, but they do have a lot of MIs. So they had less. So now this drug is being tested in 7,000 odd patients. Recruitment is already on, that whether giving weekly methotrexate to patients who have, to decrease the events, whether they are effective. Patients who had MI and who also have risk factor like diabetes. So let's see what happens. So, to conclude, no large-scale trial has yet established that an anti-inflammatory intervention that does not decrease lipid levels can improve cardiovascular outcomes. At present, the drugs that modify the classical risk factor of atherosclerosis remain the mainstay of care, and they should be, used adequately. Inflammation features prominently in the atherosclerosis disease progression and cardiovascular morbidity. I mean, inflammation has been shown in disease study lots and lots of times. So this suppressing inflammation has been the focus. It is but obvious. And some initial studies, though, like I said, with colchicine, did show some promising benefit, but no large-scale trial has been able to show any major benefit. So trials are going on. Let's see what happens. And we are also part of many of the trials. Many of I have not listed. And thank you very much.
Thank you, Professor Vimal, for illustrious and crisp talks. Can we have questions as of now before we proceed to the next session? Can we have questions from the audience? Yes, sir.
Professor Mehta, is it true that lipid level has nothing to do with the coronary artery disease? Because it has been seen in patients that those who are having normal lipid levels or even lower
Yes.
than the normal lipid levels are equally prone to coronary artery disease as compared to those who had higher. And it has been seen that those who have been having very high levels of lipid levels are not having any coronary artery disease.
So, sir, you have raised a very important point. Your point is, do lipid levels, for that matter, have any role in the atherosclerosis process as such, or this is just a hype? I'll just answer this question by one point. Last year, around almost a year back, two were published in British Medical Journal, and somehow or the other they got published, and there was lot of controversy. They've said one thing, that all this lipid hypothesis is totally false. It has no relevance to atherosclerosis. But unfortunately, there were a lot of debate, and this became a serious issue. Even the editor who had given the permission, it came to that there was called the editor should be removed. That this is not true. This is misleading the public. LDL does have a role. But important point is, and to begin with, one more thing, the hypothesis started when the mice were fed with, to begin with, mice when they are fed with hypercholesterolemic diet. Because many of our drugs, everything is based on mouse models. So they, within weeks, develop high-grade coronary artery lesions. There is no point in, no denying that LDL has a role, but there are other factors involved. Number one point, there is absolutely no issue regarding that. Number two, there is a controversy. Statins have two effects, LDL lowering as well as pleiotropic effects. We do not know, no one knows how much effect, how much positive benefit. It has positive, there is no doubt. How much positive benefit is because of LDL lowering per se, or how much it is because of anti-inflammatory effect. 50-50, 20-80, or vice versa, we do not know. But LDL, it is wrong to, as per the present data, things may change tomorrow, but as per the present data, there is absolutely no confusion that LDL lowering is very important, and increasing high cholesterol diet increases the chance of atherosclerosis. But I must say at this point of time, we are part of so many trials and all that, that it's a constellation of multiple risk factors. Genetics and other smoking, etc. Because there was a study, Dallas study, where patients who have had LDL, they did genetic study on some 3,000-4,000 patients, and patients, some gene defect, some patients who had LDL less than 100, the chances of developing myocardial infarction were 90% less. So now one important question arises that your patient may come and ask you that I am taking statins and now my LDL is only 68, and now I have developed MI again. What is this? Are you not giving effective treatment? I am on 3 years while I am taking, and now I have come with another MI. What were you doing? My LDL, you said LDL should be less than 70, now it is 60 or maybe 50. The thing is that the plaques, this is, you cannot reverse what has happened. It is not from lifetime. You have taken care of only last 3, 4, 5 years. So you cannot change this thing. So it is both, it's a constellation of risk factors. Some may be more important in one person, some may be more important in others. And if your theory may be, if I have to say from your theory, your point of view, I will say one thing. Till now, there was a trial called Improve It study. I highly doubt its credibility, but in any case, which showed estimate is beneficial. No lipid-lowering drug, apart from statins, has shown any mortality benefit, or for that matter, any benefit whatsoever, which shows a drug which has anti-related property like statin, only that drug is beneficial. Other drugs are not beneficial. Though Improve It study was recently published, which showed estimate is benefit, but benefit was, very small, and there are lots of caveats in that study. But that is how randomized trial this thing is. So, but at this point of time, we should not be believing that LDL is low, because reason being, we should not deny our patients whatever drugs armamentary which we have. We should give them highest this thing. In fact, last time their topic was polypill, and there it was emphasized why polypill came into picture was, even after stenting, 1/3 of patients stop one or the other drug. So that's why the polypill of, took over. That you have to, whatever evidence base we have, we must apply to each and every patient.